So next is about the organophosphate poisoning. So what are the organophosphate compounds? So these are the compounds which are found in the insecticides and also in the nerve agents which are used in the warfare. Okay, like tabun, sarin and soman. Okay, so in these compounds only the organophosphate compounds are present. Okay, next this can be divided into diethyl compounds and also dimethyl compounds. Okay, so these are divided into dimethyl and also diethyl compounds. Okay, so what are the diethyl compounds? Ethyl compounds are the chlorpyrifos, diazinon and parathione. Okay, chlorpyrifos, diazinon and parathione, and dimethyl compounds are the dimethoate, malathione and phendione. Okay. So next is the mechanism of toxicity. So the mechanism of toxicity here, mainly these organophosphorus compounds are readily absorbed through the skin, conjunctiva, mucosa, gastrointestinal and the respiratory tract. Okay, so after being absorbed, what these compounds are doing means these are acetylcholine esterase enzyme inhibitors. Okay, these are the acetylcholine esterase inhibitors. So what happens? Normally what is the function of this acetylcholine esterase? Okay, acetylcholine esterase, its function is breaking down the acetylcholine. Okay, it will break down acetylcholine into acetic acid and choline. So that is the function of the acetylcholine esterase enzyme. So these organophosphorus compounds will come and bind with this acetylcholine esterase inhibitors and will inhibit this enzyme. Okay, so what happens in OP poisoning? These organophosphate compounds will go and bind to this acetylcholine esterase enzyme and form a complex, that is the organophosphate acetylcholine esterase complex. Okay, and this results in the inactivation of the acetylcholine esterase enzyme. Thus what happens? So when this enzyme is inhibited, this will lead to the accumulation of acetylcholine at the cholinergic synapses. Okay, there will be an accumulation of this acetylcholine at the cholinergic synapses and this leads to the muscarinic and nicotinic manifestations of this toxicity. Okay, so this will lead to the manifestations of this toxicity. And initially this organophosphates acetylcholine esterase complex which is formed, and that is a reversible compound. Okay, here this acetylcholine esterase enzyme can be again reactivated by a spontaneous hydrolysis. Okay, this can easily reverse that process. Okay, then again acetylcholine will become reactivated, but after as time elapses, aging occurs for this organophosphorus, that is dealkylization of OP occurs. Then what happens? This compound will become reversible. Okay, so initially this organophosphorus acetylcholine esterase complex is a compound that can be reversible. This acetylcholine esterase can be reactivated by cutting this bond with the organophosphate, but later this acetylcholine esterase complex that become a compound which is irreversible compound. Okay, so while comparing the aging, for dimethyl compounds aging is shorter, like within few hours aging occurs, but compared to diethyl compounds within 24 hours only aging occurs for these organophosphorus compounds. Okay, so next is the clinical features. So first phase is the acute cholinergic phase, and this acute cholinergic phase that starts within hours and then lasts for 24 to 3 days. Okay, here mainly what are the symptoms seen are we have a mnemonic for that is sludge BB acronym. Okay, this is the sludge BB acronym, that is first S for salivation, L for lacrimation, urination, defecation, gastrointestinal cramps. Okay, and emesis. Okay, as well as the triple B, that is bradycardia. In 80% cases bradycardia will be there, plus bronchospasm and bronchoria. Okay, so these are the main symptoms seen, and along with this there will be meiosis, constriction of the pupil, and CNS manifestations like delirium and psychosis. Okay, and in muscles there will be fasciculations and muscle weakness, and due to the nicotinic activation 20% cases will be having tachycardia. And also some of the patients are having complications like coma, seizures, respiratory failure, arrhythmia. Okay, AV blocks, QT prolongation and Torsades D pointers. Okay, these are the complications. And I said no, mainly in organophosphate poisoning there will be pinpoint pupil. Okay, pinpoint pupil, but the pinpoint pupil is not only seen in this organophosphate poisoning, it also seen in cases like opioids, like morphine cases, Horner syndrome. It is also seen in pontine hemorrhage, iridocyclitis, and also when the drugs like clonidine and antipsychotics are taken. Okay, so pinpoint pupil has so many DDs, but in organophosphate poisoning also this pinpoint pupil is seen. Okay, so other than the sludge BBB triple P, that is salivation, lacrimation, urination, defecation, gastrointestinal cramps and emesis, plus bradycardia, bronchospasm and bronchoria. Okay, so after the acute phase, there what develops? Intermediate syndrome develops. Okay, so after the acute phase, what develops? Intermediate syndrome, and this is seen only in 20% cases. Okay, so after the acute phase, when that develops, usually 1 to 4 days after the exposure, mainly due to the redistribution of lipid soluble organophosphates into the blood. Okay, normally organophosphates are in our blood, and lipid soluble organophosphates get redistributed into the blood. Okay, so due to this, the intermediate syndrome develops. Here what mainly happens means, at the neuromuscular junction, the receptors are getting dysfunctioned. Okay, receptors are dysfunctioned at the neuromuscular junction. Okay, and there will be neurological manifestations. What are the neurological manifestations seen here? Mainly neck flexion, weakness is there, decreased deep tendon reflexes, cranial nerve abnormalities, and proximal muscle weakness and respiratory failure. Okay, so these are the neurological manifestations which are seen, that is in the intermediate syndrome. Okay, so what I've seen, that is seen in only 20% cases, mainly due to the receptor dysfunction at NMJ junction, and mainly neurological manifestations like neck flexion, weakness, decreased deep tendon reflex, respiratory failure, proximal muscle weakness, and cranial nerve abnormalities will be seen. Okay, so next is third is the delayed polyneuropathy, and it mainly happens after like 2 to 3 weeks of exposure only. Delayed polyneuropathy start occurs. Okay, it mainly occurs due to this inhibition of the acetylcholinesterase by the organophosphate compounds. Okay, that is the main cause for this delayed polyneuropathy. And here what are the enzymes affected here? Mainly in the RBC, the true cholinesterase enzyme, and in the plasma, the pseudo cholinesterase enzymes, and also the neuropathy target esterase. Okay, these are the enzymes affected here. And what are the manifestations? Predominantly neurological manifestations are there. Other than there will be symmetrical ആയിട്ടുള്ള polyneuropathy. Okay, so preferential affection to long myelinated neurons. Okay, lower limbs. Okay, but symmetrical polyneuropathy will be there, and also long myelinated neurons of the lower limbs are primarily impacted, resulting in the flaccid paralysis of lower limbs and foot drop. Okay, later involvement of upper limb and wrist drop. Okay, so initially there will be lower limb paralysis and foot drop, and later there will be only affection of the upper limb and there will be wrist drop. Okay, so long myelinated neurons of the lower limb are primarily impacted. Okay, mainly there will be symmetrical polyneuropathy. Okay, so these are the manifestations in delayed polyneuropathy. So how we will be diagnosing this as an organophosphate poisoning? Okay, that is by first the clinical presentation will be like a pungent garlic like odor or kerosene like smell will be there, and also you should do the toxicological analysis of the blood, gastric secretions and the urine, and also measure the RBC's acetylcholinesterase, which are the true acetylcholinesterase, and also the plasma acetylcholinesterase, which are the pseudo acetylcholinesterase. Okay, you should measure both these acetylcholinesterase and both levels will be decreased. Okay, so that is the diagnosis part. Next is the management. So here first access the airway, breathing and circulation. Why? Because it is an emergency condition. Okay, emergency situation, and also give oxygen for the patient and obtain IV access. Okay, you should obtain an IV access, and you should do the normal blood routines എല്ലാം ചെയ്യണം. RFT, LFT and electrolytes you should do. Then also surface decontamination ചെയ്യണം, that is remove the contaminated cloth, wash the skin thoroughly with the soap and water. Okay, that is surface decontamination. So first assess airway ABC, then give oxygen, then obtain IV access to blood routines, RFT, LFT, electrolytes. Then you should do the surface decontamination, that is by removing the contaminated clothing and wash the skin thoroughly with the soap and water. After that you should do the GI decontamination, that is by gastric lavage. Okay, only within 1 to 2 hours of the patient coming, do the GI contamination using gastric lavage. Then administer activated charcoal, that is 1 milligram per kilogram, maximum 50 gram. Okay, that is controversial. So I administer activated charcoal, that is how much? 1 gram per kilogram രീതിയിൽ. Then induction of MSS is contraindicated. Okay, MSS in the induction here it is contraindicated. Only GI decontamination by gastric lavage, or you can administer activated charcoal. Induction of MSS is contraindicated. Okay, and you should start the antidote. Here what is the antidote? That is atropine. Okay, atropine used to counteract the muscarinic effects by blocking the acetylcholine receptors and this preventing cholinergic activation. Okay, no effect on nicotinic receptors. So what is the main reason here? Here mainly muscarinic effects are there. That is mainly this acetylcholines are not get converted into acetyl or choline. So this acetylcholine are more acting and this leads to muscarinic effects or manifestation. So here this atropine will go and bind to the acetylcholine receptors and block that receptors. Okay, thus this will counteract the muscarinic effects. Okay, so this is preventing the cholinergic activation also. So no effect on but this has no effect on the nicotinic receptors. Okay, so how we are giving the atropine? Here there is a protocol for that, that is atropinization protocol. Here the like commercially available atropine preparations are 0.6 milligram per ml. That is in ampules we can give, there will be 0.6 milligram per ml, and in vial that is 1 milligram per ml. Okay, so this is the atropine concentration. Okay, commercially available atropine preparations ആണ് ഇതൊക്കെ. ആംപ്യൂൾസിലാണെങ്കിൽ 0.6 milligram per ml and in vial it is 1 milligram per ml. Okay, so what is the initial dose? Initial dose എന്ന് പറയുന്നത് it is 1.8 milligram IV bolus. Okay, 1.8 milligram IV bolus and double the dose every 5 to 10 minutes. Okay, every 5 to 10 minutes double this dose until atropinization is achieved. Okay, and at this time close monitoring of the vitals is required. And what are the targets of atropinization? What are the targets? First one, clear chest on auscultation with no wheeze. Okay, the chest should be clear and with no wheeze, and dry axilla. Then heart rate should be increased and should be greater than 80 beats per minute, and pupils will not be no longer pinpoint, and SBP systolic blood pressure is greater than 90 mmHg. So these are the targets of atropinization. And there is a fact about atropine is that atropine also can induce psychosis. Okay, so in older days it was considered as an endpoint, but not anymore. Okay, this atropinization maintenance, how this atropinization is maintained in that patient, that is you should maintain an infusion at a dose equivalent to the 10% of the atropinization dose. So here how that is giving means you should know the total atropinization dose. Okay, the total atropinization dose that we given adinde 10%. Okay, so we should give an infusion at a dose that is equivalent to 10% of the total atropinization dose every hour. Okay, every hour should be given, and you can taper the dose and stop after. You can taper it low. You can reduce the dosage, and after that you can stop after 2 to 5 days. You can stop that dose. That is mainly depending on the clinical response. Okay, and there is an alternative to atropine, that is the glycopyrrolate. It does not cross the blood-brain barrier, which has fever, CNS side effects, can be used as an add-on if atropine induces psychotic features. Okay, so what is the alternative to atropine? That is the glycopyrrolate. Okay, so other than the atropine, here oxanes can also be used. Oxanes in examples are pralidoxime and also what? Obidoxime. Okay, pralidoxime and obidoxime are the oxanes, and these oxanes and these are the cholinesterase reactivating enzymes. Okay, I told that when these compounds get aged, then this cannot be given. Okay, this should be given before the aging has happened. Okay, if the aging has happened, then it is an irreversible compound. We can't reactivate that enzyme. Okay, so till aging, before getting aged, we can give the cholinesterase reactivating agents like oxanes. Okay, so oxanes can be given, and this can counteract both muscarinic and nicotinic effects. The dose of this is 30 milligram per kilogram. Maximum 2 gram can be given, and it is given IV slowly over 30 minutes. Okay, and followed by an infusion of 8 milligram per kilogram per hour. Okay, and this can be continued until atropine is given. Okay, like 2 to 5 days. So that's about oxanes, and the additional agents are magnesium sulfate may also have some benefit in organophosphate toxicity management. Okay.